the doctors through Medalle as well as show us a technique in order to rescue a fiber-free luxated artificial iris into the anterior chamber in order to be able to refixate it to the sulcus without the need of extracting the artificial iris. For this technique, the surgeon chose the option of doing Hoffman pockets as an alternative approach in order to refixate and rescue this artificial iris that was previously inserted into the capsular bag but got luxated because of the fibrosis of the capsular bag that at the same time was also fixated to the sulcus. So we believe this is a very interesting video. This shows you a novel approach about how to refixate an artificial iris into the sulcus through a scleral fixation using Hoffman pockets. So thank you very much, Dr. Medalle.
In this video, we tackle an uncommon circumstance of an anterior luxated artificial iris, where what was done can be a learning experience for other displaced intraocular implants and making quick intraoperative judgments. We call this presentation, How to Save an Iris. I have no financial disclosures. Our case was a 60-year-old female who had trauma in her left eye 40 years prior. This resulted in traumatic aniridia and a cataract that was temporarily subluxed due to zonular weakness. Her visual acuity was hand movement, probably due to optic atrophy. We performed phaco and fixed the capsular bag using the Canabrava technique. Then we implanted a monofocal IOL as well as a fiber-free artificial iris in the bag where it was centered and stable. The complex was centered and stable with unremarkable findings. 9 months after, however, there was anterior luxation of the artificial iris, probably due to capsular fibrosis. There was endothelium contact, but fortunately, cell count was not substantially low. We had to plan our next move, but had to consider that the patient had poor visual prognosis, but still desired to maintain the previous symmetry of her eyes. But we couldn't place the impact pack in the fibrous bag. Do we explant or refixate? We decided to use the Hoffman pocket technique since by design, there would be less dissection leading to less complications while providing comfort for the patient. We could attain implant stability without as much suture handling. Well, most talk about IOL fixation and others have mentioned iridodialysis repair. So we thought, maybe this can be done for an artificial iris as well. The 2-point fixation for each Hoffman pocket may provide better stability for the iris. The sutures go through full thickness sclera and are retrieved, tied and tucked under the tunnel, well concealed under the roof. With this technique, there was no need to externalize the artificial iris for flanges or any suture for that matter. Now here, we have the pre-op picture of the patient. The dotted lines present where we plan to place the pockets for fixation. For ease, we are rotating the picture to simulate the surgeon's view. On the left side of the video, you can see the flange from the Canabrava fixated bag. The peripheral clear corneal incision in the temporal area is marked. A guarded diamond step knife is set at 300 micrometers depth to make a 1 clock hour corneal incision 1 mm from the limbus. The scleral pocket is dissected 3 mm posteriorly using a crescent knife. A 1 mm paracentesis is created opposite. A 27 gauge needle is passed 2 mm from the limbus to the conjunctiva and sclera full thickness, which then perforates the artificial iris. A double-armed 10-0 proline suture on the straight needle is inserted through the opposite incision docked into the 27 gauge needle. The needle with the proline suture are removed externally through the scleral pocket and conjunctiva. The same is done 2 mm adjacent to the first pass, perforating the artificial iris adjacent to the first pass. The second arm of the proline suture is docked as well and all are removed to the sclera full thickness. This enables the surgeon to manipulate the artificial iris. Each suture is retrieved through the scleral pocket opening by passing a Sinskey hook and pulling the trailing ends of both sutures through the corneal incision. The same technique is performed on the opposite side. The diamond step knife is also used to make a similar incision. The video has been flipped 90 degrees for easier comprehension since we did this part of the surgery from the temporal side of the patient. Now, unlike the prescribed technique by Dr. Hoffman, we did not place the incision 180 degrees away from each other, rather 120 degrees away more or less, for the purposes of customized fixation points for the artificial iris, since we also plan to have 3. A 27 gauge needle is passed similarly through the conjunctiva, full thickness of the sclera, and the artificial iris. Again, double-armed 10-0 proline sutures and needles are docked into the 27 gauge needle for the fixation points. At this point, we were alerted because of noticeable bleeding. And indeed, there seemed to be an increase in IOP. We suspected subchoroidal hemorrhage, therefore we avoided a third Hoffman pocket and decided to use remnant iris to give support to the superior part of the artificial iris. The knots of the two pockets are tied after centering the artificial iris, after which the knots are concealed under the protective roof of the scleral pocket. We then proceeded with a single pass fourth row pupilloplasty to cover the superior portion of the defect. Some INA was done, then the wounds were all closed. This is the slit lamp photo flipped, simulating the surgeon's view and the dotted squares where the Hoffman pockets are. We flipped the photo again to show that the pupilloplasty replaced the planned third pocket superiorly. At 6 months follow-up, the implant was stable and centered. We were able to retain and salvage the artificial iris. So what have we learned? We can refixate an artificial iris with this technique. And although we planned for 3 pockets, the focal pupilloplasty with only 2 pockets provided adequate stability. We also learned that no matter how good you plan, anything can happen, such as that of our case. As corneal surgeons, we always have to adjust to the circumstances. Thank you for watching!